Jerry Shields. He comes a long way to speak to us today in the meeting. So he will talk about the past and present management of melanoma. Professor Jerry Shields.
Thank you. It's a great pleasure to be here and share some thoughts with all of my colleagues. Just to mention, later this afternoon, it's hard to read the program. I think late this morning, we're going to have a wonderful course on masquerade syndromes, and there's about 10 different titles in the program, and we don't understand it, but I hope that those of you who are interested in ocular oncology will be there, because we're going to have a great time and see some good cases, and it's at 11 o'clock, but I don't know exactly where at the moment. Anyway, let's get started. It's a pleasure. How can I change the slides there? It's a pleasure to be here and share some thoughts with my colleagues at this time. Okay, thank you. I'm going to present a modification of the Scapin's lecture that I gave at the American Academy of Ophthalmology a year and a half ago. And this is a modification of that talk. It was called, I've been assigned the topic for this meeting, part of the Scapin's lecture, Past, Present, and Management of Uveal Melanoma. It's a long talk, but I'll cut down to the time limits allotted. So let's say a few words about management of posterior uveal melanoma as of today. The past first. We're going to say a few words about the past. Until the early 1970s, enucleation was performed usually by the general ophthalmologist for any pigmented lesion, regardless of size, suspected to be a melanoma. This was undisputed. It was thought to be the only way to save lives. However, earlier studies showed that about 20% of eyes enucleated for suspected melanoma proved to have a benign lesion. But in the 1970s, diagnostic accuracy began to improve. The reasons for this included the advent of retinal specialists and the use of the indirect ophthalmoscope and people trained in ocular oncology. Fluorescein angiography, ultrasonography were also used. And I will mention one thing historically, and that is the radioactive phosphorus uptake test, which most of you haven't heard of, but we used it quite a few years ago. Can I go back one here? The radioactive phosphorus uptake test was done by injecting radioactive phosphorus intravenously, and 48 hours later taking a count over the tumor, and melanomas had a much higher count of uptake of radioactive phosphorus. And this was removed and used for hundreds of cases at that time. And it was a very accurate test. However, it ultimately fell into disuse, even though it was highly accurate, because at that time we began to develop fine needle aspiration biopsy for cytology that would give us a more definitive diagnosis. Fine needle biopsy was performed by passing a needle through the pars plana into the suspected lesion, and cells could be obtained that would verify the diagnosis of melanoma, and immunohistochemistry could be used to further delineate the exact diagnosis. Now, in the 1970s also, Dr. Zimmerman, who many of you may not have heard of, he noted with his group an unexpected rapid rise in mortality following enucleation. And they suggested that enucleation can induce metastasis by increasing the intraocular pressure when the optic nerve was cut. Heated discussions arose at that time, and other specialists like Blody and Manscott and others disagreed with Zimmerman. Zimmerman said, well, let's just observe most melanomas until we prove they're growing, because enucleation could be dangerous. Others disagreed, and they got so exciting at some of the meetings that Manscott from Holland actually turned to Dr. Zimmerman in one of the meetings and said, Dr. Zimmerman, you are a murderer because you watch melanomas. And the heated debate went on for a long time. So people began to look for methods of treating melanomas other than enucleation. We and others used partial lamellar sclerouvectomy, a term that we used to show the removal of the lesion by a scleral flap. The tumor was taken out with the inner scleral fibers, leaving the retina intact if possible. And we were able to do these procedures where you can see a large mushroom-shaped melanoma removed with a good scleral base in that situation. Here's a patient that had the PLSU, partial lamellar scleral uvectomy. You can see the inferior melanoma with the serous retinal detachment. And it was removed by leaving the retina intact. As you can see after the photographs, the retina was still intact, removing a choroidal tumor. Quite difficult surgery, but was used for a long period of time. You can see the retinal vessel verifying that it is intact. That patient that I just showed you has now been followed for 30 years. Never developed a cataract, never developed any other complications, didn't have any radiation, and did very well. And a number of patients have done well for quite a few years. Well, that's what I had to say about the past. There's a lot more to say, but I'd like now to share with you some thoughts about the present management of uveal melanoma. At this time, we have techniques like transillumination, TTT, radiotherapy, combined plaque and radiotherapy, and a number of other methods listed there. Here you can see a patient treated with TTT. Despite the controversy, it's a good method of treating some of these tumors. You can see before and after TTT, a beautiful result in that case. Plaque radiotherapy is by far the most common method of treating uveal melanoma today, and we treat anywhere between 6 and 12 new patients each week in our office for melanomas with plaques. Here's an example of a plaque supraotemporally before and a couple of years after treatment, showing a beautiful response with no serious complications. Brachytherapy for posterior uveal melanoma is used also by giving anti-VEGF, TTT, and PRP, all to lessen the complications of the radiation, and that seems to be working well in preliminary studies. A couple of special considerations, not randomized in the collaborative melanoma study, were tumors that were juxtapapillary, ciliary body, large choroidal melanomas, and melanomas with extraocular extension. And I want to stress that they didn't study that in the COMS, but these are all methods where it can be used. For example, here's a juxtapapillary melanoma, subfoveal, showing an excellent result a year later. They do get some complications in the long run, but a beautiful result. Extraocular extension is often thought to be a reason to do an orbital exenteration, and that's wrong. We only have to do about 5% of orbital exenterations for extraocular extension. They respond nicely to plaque radiotherapy. Here you see a choroidal ciliary body melanoma invading the iris and the sclera, and a few months after treatment, without any biopsy, the tumor in the ciliary body and the iris and the sclera have all disappeared. The sclera tolerates this very well. So current trends, despite the identification of risk factors, many ophthalmologists still observe borderline lesions, waiting for growth before initiating treatment. And Carol may have some new things to say about that shortly. We wonder if that's a good philosophy. We ask the question, are ophthalmologists unique in observing these possible malignant lesions? In fact, if we look at cancer management and other specialties, early diagnosis and prompt treatment are responsible for improved prognosis. And this seems to be true with colon cancer, breast cancer, cutaneous melanoma, and others. Look at other ocular tumors, however. Retinoblastoma, rhabdomyosarcoma, and eyelid sebaceous carcinoma have all enjoyed improved prognosis by far, but they are not observed. They're treated promptly. Choroidal melanomas, on the other hand, the prognosis remains poor, even though we have equipment for earlier diagnosis and excellent methods of treatment. The question comes up, are we waiting too long in observing some of these? I show you here 8 photographs of small pigmented lesions that many of you may call a nevus. All of these were observed, slight growth documented, and then promptly treated with either plaque or enucleation. And every one of these patients died of metastatic melanoma. Are we waiting too long, and should they have been treated earlier? There are indeed arguments for treating choroidal nevi at an early stage. As I just showed you, they can be malignant in time. Small melanomas can metastasize, we've showed that. And metastasis generally causes death. And what the heck, we have another eye, so why not treat all nevi? Well, before you jump to conclusions, there's strong arguments against treating choroidal nevi. They occur in 5% of the population. Melanomas are uncommon, and many would be treated unnecessarily. Most have an excellent prognosis, and growth and metastasis are rare. And treatment causes visual loss. And finally, any ophthalmologist who starts treating all choroidal nevi is going to come under intense criticism by colleagues. So, we cannot and we should not treat all choroidal nevi. But there is a trend toward earlier treatment, and the risk factors that Dr. just mentioned can help select which ones to treat. She mentioned 2 fine small ocular melanoma using Helpful Hints daily. We use that on all of our patients and write on the chart the findings. Here I show you 2 lesions, one above and one below. They're exactly the same size. One has virtually no risk, the one above, for metastasis, and the one below, the same size, has multiple risk factors and has a great chance of metastasis. So there's all these factors are very important. So today, when a patient is treated, plaque radiotherapy, a needle biopsy can be done. And when the needle biopsy is done at the time of plaque treatment, we get cytogenetics and diagnostic studies. If it's an enucleation, we make an opening in the globe after the eye is removed, take out fresh tissue, and do the same studies. So that's been a few comments about the past and the present management of uveal melanoma. There's great changes taking place, and at this time I think Dr. Carroll will say some words about future management of choroidal melanoma. Thank you.
Okay, may I introduce Professor Carol Shields to talk about the future of melanoma management.
Thank you. I'd like to thank Dr. Rojanaporn for inviting me here to her country of Thailand. This is my first time in Thailand, and so far it's been great. And Dr. Goto, it has been a great pleasure working with him on the program. I have one financial disclosure. I'm on the Scientific Advisory Council for ARA Bioscience, and I will discuss a protocol from this company in my talk. Do you have the... Good. Okay. Thank you. So the management of melanoma is not just one single person removing an eye or putting a plaque on an eye. It's not a group of eye doctors working together. It is a whole team working together. Systemic oncologist, ocular oncologist, researchers, all working together. And in Philadelphia, we work very tightly with our general oncologist, Dr. Takami Sato, from Jefferson Medical School. We also work with the Wistar Research Institute and the University of Pennsylvania. So it's a big team of people working together to serve a single patient. I'd like to talk to you about innovative new pharmacological treatments, namely immunotherapy and small molecule inhibitors for the management of uveal melanoma. This is sort of the future, but really, this is what's going on now. So where are we heading with uveal melanoma? You've heard 3 speakers this morning talk about early detection. That relies on you detecting melanoma when it's very small and referring it into your ocular oncologist in your country. If we can identify melanoma when it's really small, we have wonderful potential new treatments for managing these small lesions. And the one treatment I'd like to speak about is a local treatment, namely light-activated AU-011. You've heard this morning about radiotherapy for uveal melanoma. It works, whether you use plaque radiotherapy or proton beam radiotherapy. Good control, 98% control with both methods. The problems are that patients tend to develop radiation side effects, such as radiation retinopathy, papillopathy, cataract, glaucoma, scleral necrosis, leading to occasional, 6% of the time, loss of the eye and loss of visual acuity in about 60 to 70% of cases. So there are a lot of complications of radiation, despite the fact that it can control the intraocular tumor. We need a therapy with a better side effect profile. So light-activated AU-011 is a new class of therapy. It's selectively targeted to tumor cells. The technology is that it involves virus-like nanoparticles. It was developed in Cambridge, Massachusetts, which is near Boston, Massachusetts. It's a human papillomavirus capsid. It is not infected and there's no DNA. It selectively binds to heparin sulfate, which coats the cells of melanoma and other cancers. And a chromophore is attached to this HPV capsid. And laser light is used, and it is uptaked by the chromophore and causes precise tumor cell death. So where's the evidence? This sounds unreal. Well, this has been studied in animals in Canada and in the United States. And it's been presented at ARVO in 2 sequential ARVOs. And in the presentations on the in vivo efficacy of this novel, first-in-a-class drug for primary uveal melanoma, they found where the nanoparticles injected into the eye, laser light is then delivered to the chromophore. They found successful complete response of the melanoma with complete regression in all cases, complete tumor necrosis. So human trials are scheduled. We will be working with Dr. Ivana Kim and Evan Grigutis from Boston, and there are several centers in the United States that will be investigating this new method for treating uveal melanoma. We have a phase 1-2 trial design where we treat small to medium choroidal melanoma, those that show risk factors. This is where risk factors become important again. Tumor greater than 2 millimeters in thickness with subretinal fluid and with one of the following: orange pigment, flashes or floaters, or vision loss. So here's what we're going to be doing. We have an eye with a small melanoma. We will inject these virus-like nanoparticles. They are selectively attracted to the heparin sulfate that sit on the surface of the melanoma cells. They're coupled with a photosensitive drug, and we deliver light into the eye, and it causes complete tumor regression with no lateral damage to the eye. Sounds exciting. So we will, perhaps at your next meeting in a year or 2, be able to give you some of the results. Then now I'd like to focus on some new and innovative systemic therapies for uveal melanoma, beginning with targeted drugs. You know, most of us in the United States are offering fine needle aspiration biopsy for genetic testing of uveal melanoma. We know the pathway for uveal melanoma, and we can identify where the mutation is. If it's at GNAQ, we now have a GNAQ vaccine that's been tested in mice. We have MEK inhibitors that has already been tested for uveal melanoma and shown slight promise. So we are using this method to identify places along the pathway for targeted drugs. And there's another way to treat systemic metastatic disease using vascularization blockade, using Sutent. Sutent is an oral small molecule. It's targeted to tyrosine kinase and VEGF. It's an anti-VEGF, oral anti-VEGF. It's used to treat renal cell carcinoma, GI stromal tumor, and other cancers. And now it's used in testing for high-risk patients with uveal melanoma. So those patients who have chromosome 3 or 8 mutation or classified as class 2 and those with large tumor size are now put on Sutent to prevent metastatic disease. So we have a study now that's undergoing publication where we compared 54 patients who received Sutent versus 74 who didn't. And this was a matched group. These were all high-risk patients. And the patients who received Sutent had 80% survival compared to only 57% survival for those who didn't receive it. So we do think there is some promise using this anti-VEGF orally. It's a method to prevent metastatic disease. Last, I'd like to talk to you about what I think is the most exciting, and that is immunotherapy for uveal melanoma. Immunotherapy, you can use immunotherapy in various different ways. One is checkpoint inhibitors. I'll explain that. It's where you unleash the T cells. The next is vaccines. It's where you train the T cells. And the next is T cell activation, where you educate T cells. Immunotherapy involves teaching the T cells to do what you want them to do. So I will start with checkpoint inhibitors. Now, Dr. Goto asked me a question earlier about checkpoint inhibitors. See, the T cells are normally controlled by 2 points, CTLA4 and PD-1. And these are called checkpoints. They prevent activation of the T cells. And the inhibitors go and rest on these. Can you put my talk back up? My talk just, can you press play? Right up in the top, third from the right, from the left. Right there. Thank you. I'm going to go back one. So these checkpoints, if you give a checkpoint inhibitor like ipilimumab or pembrolizumab, it blocks these inhibitors and it allows the T cells to activate. So at the recent 2006 American Society of Clinical Oncology, where they were talking about cutaneous melanoma, checkpoint inhibitors are huge in the field of skin melanoma. Greater than 50% response, and 10% of patients have complete cure with metastatic disease if they use checkpoint inhibitors, mostly with pembrolizumab. But when they looked at uveal melanoma, they found that only 3% respond. Very bad, poor response. So these are not yet ready for prime time with uveal melanoma. How about vaccines? Well, vaccines have been studied for uveal melanoma. It sounds like an ideal therapy, using dendritic cell vaccine, which is loaded with the patient's melanoma antigen inactivated to stimulate an immune response. The group from the Netherlands in 2014 published on vaccines for uveal melanoma in patients who had metastatic disease, and they found 30% of patients had a response and had prolonged survival. So there's one step forward in vaccine use. And then they went even further and they looked at high-risk patients, not with metastasis, but patients who were high risk for metastasis. And they found that if they had a response in their T cells, they had significantly reduced metastatic disease compared to those who didn't have a response. So there may be a role for vaccines in the management of uveal melanoma. The last part of my talk will be regarding T cell activation. One way to activate T cells is to use tumor-infiltrating lymphocytes. This is used at the National Cancer Institute in Washington, D.C., where they actually remove the patient's lymphocytes, educate the T cells to fight melanoma, then they give the patient chemotherapy to wipe their immune system, then they re-infuse the educated T cells. It's a very toxic therapy, and very few of our patients undergo this therapy. But the type of therapy which we're really excited about is immune-modulated T cells against cancer. It's called ImmTAC. This is a technique that was developed in Oxford, England. Melanoma-specific ImmTAC. It redirects the T cells to fight cancer using a manufactured antigen-presenting cell, or APC. And currently we have trials underway at Jefferson and Wills Eye Hospital. You see, this is how it works. Right there is your antigen-presenting system that attracts the melanoma with the HLA2 receptor. Then the CD3 receptor attracts the T cell. So it actually brings the T cell to the melanoma, and the T cell is activated to fight the melanoma. We have many patients on this medication, all of whom have metastatic disease, and thus far only one patient has died, and I can give you results in 1 year because we want to have at least 1 year follow-up. So over the past few minutes, we've talked about future innovative therapies for uveal melanoma. Well, I think the future is now. And stay tuned, there will be a lot more to come because this is a really exciting part of melanoma. Thank you.
Would there be any questions from the audience to any of the speakers? Any comments from our Boston colleagues about the use of immunotherapy or
any new therapies that you might have that might seem to be beneficial. I think this is where the future is going to be. Identification of melanoma when it's tiny. You get the patient with the melanoma in to see your ocular oncologist. They'll get rid of it by whatever method they use, and then the patient will be sent for immune therapy or other treatments. I think that's where we've been lacking with regard to melanoma, systemic therapy to prevent metastatic disease.
I agree with you. I think that immunotherapy probably is the future. However, there are a lot of problems. There are two major companies, probably you're aware of that, Juno and Kite, that use immunotherapy, and they have good results, but the side effects are tremendous, and a lot of patients died actually because of the treatment itself, and also a significant number of patients have systemic side effects. So it does work, we're on the right track, but I think we have a long way to go.
You make a good point. The side effects, basically with the immune therapy, if it's a non-specific immune therapy, such as ipilimumab or pembrolizumab, you're basically creating an autoimmune state in the patient. So you can imagine all the side effects of making your patient with melanoma become autoimmune. They're going to get autoimmune colitis with diarrhea, autoimmune hepatitis, autoimmune dermatitis. So if you're creating a really bad autoimmune state, some of the more specific anti-melanoma immunotherapies also have a little spillover and create an autoimmune state. For example, the last one I just talked about, MTAX, these patients from head to toe lose a lot of their pigment, so they become gray-haired from head to toe, and they develop vitiligo on their skin, which is not a big problem, but you have to be able to handle all of these autoimmune complications. I'll just give an anecdotal story. Some of you might remember Jimmy Carter was the president of the United States several decades ago, and he developed skin melanoma and developed metastatic disease to the brain. He was, estimated to live maybe 1 or 2 months. He was put on ipilimumab, and it was not going well, and he developed side effects. So they changed him to the other checkpoint inhibitor, pembrolizumab, and that was 1.5 years ago. And they just recently did MRI scan of his brain, and he's without any tumor. So these new checkpoint inhibitors have completely changed how we manage skin melanoma.
Thank you everyone for coming. We are right on time, so hopefully you have a wonderful session with us. Thank you very much.